Hi, I'm Tatiana Falcone, a child psychiatrist here at Cleveland Clinic Epilepsy Center. Welcome to a series of webinars targeting educational topics for parents of children with epilepsy. We assemble a great team of doctors, psychologists, nurses, social workers, parents, patients with epilepsy, and epilepsy educators to help you navigate all the different challenges that epilepsy may present. Project Care for Epilepsy is designed to improve care coordination, increase social support, provide education, and increase engagement for teens with epilepsy and their families. This project is supported by the Health Resources Services Administration of the U.S. Department of Health and Human Services. The information, content, and conclusions presented here are those of the authors and are not the official position or policy of HRSA, Health and Human Services, or the U.S. government. At the end of each webinar, there will be a link to answer 4 questions about the new topic you just learned about. Please take a moment to answer this quick survey. It will help us understand your needs better. The Cleveland Clinic Epilepsy Center welcomes and thank you for your participation in this educational series.
Hello, and welcome to our webinar on ADHD, or Attention Deficit Hyperactivity Disorder, and epilepsy. I'm Dr. Jane Timmons-Mitchell. I'm a child clinical psychologist from Case Western Reserve University, and I'm very pleased to be here today with Dr. Tatiana Falcone, a child psychiatrist in the Epilepsy Center at the Cleveland Clinic. Inattention, which obviously if you're talking about Attention Deficit Hyperactivity Disorder is a very important feature, has been reported as the most frequent comorbidity in youth with epilepsy. It tends to appear before the epilepsy in more than half of the cases, and it can be related to the side effects of medication or to the seizures itself. It has major impact on the quality of life of children and youth with epilepsy. So we're going to spend some time discussing it in fair detail today. What is ADHD, or Attention Deficit Hyperactivity Disorder? ADHD is a disorder that makes it difficult to pay attention, stay on task, and control behavior and thinking. It usually starts before age 7. Symptoms have to be present in 2 places in the child's life, like, for example, at home and at school. Some of the symptoms include inattention, impulsivity, and hyperactivity, and we're going to talk more about what we mean by those. Some people have all of these symptoms, and some have only one of them or a combination of some of them. The prevalence speaks to how many children have ADHD, and we know that many children with epilepsy have ADHD. In the general population, or people without epilepsy, ADHD affects 3 to 7% of children, and in the population with epilepsy, it affects 12 to 57%, which is a huge range, but obviously at the high end is more than half of all of the children and youth with epilepsy. Inattention occurs in 15 to 40% of youth with epilepsy. It can begin as young as 3 or 4 years, and half of the time it precedes epilepsy. In the general population, more boys than girls have ADHD, but in youth with epilepsy, the number of boys and girls is about equal. 50 to 80% of children continue to have symptoms of ADHD into adolescence and 40% into adulthood. Other impairments with ADHD, it can especially make doing schoolwork difficult. There are specific learning disabilities that children with ADHD often have. They can have disabilities in reading, spelling, and math, and up to 1/3 of the children have these, and half of children with ADHD require tutoring in school. Suspensions and expulsions in school are common, usually around behavioral issues. Language disabilities have been observed to be prevalent. And physical development can result in greater proneness to accidental injury and even sleep dysfunction. Emotional development may make it hard for children and youth with ADHD and epilepsy to make friends. They may have more conflicts with siblings and parents. These have been reported. And in the teenage years, more teen pregnancy and STDs, or sexually transmitted diseases, have been observed. How is ADHD diagnosed? It's diagnosed as a persistent pattern of inattention and/or hyperactivity or impulsivity more than others of the same age. A child psychiatrist or child psychologist can help with the diagnosis. Information is gathered from parents and teachers, and that's because, remember, of needing to identify areas affected in more than one area of the child's functioning. Rating scales can help with the diagnosis. So if your child is suspected of ADHD, you may be asked to fill out a scale, and you may be asked to give one to your child's teacher. At this point, I'm going to hand the presentation over to Dr. Falcone, who's going to speak, first of all, to public health issues in ADHD.
So I think it's very important to think about why should we worry about ADHD. And people will say, well, when people grow up, things are going to get better, and they might not consider ADHD as something that can impact their everyday life. So from the public health perspective, we know that patients with ADHD have 50% more bike accidents if they're not treated. They might have 33% increase in ER visits, perhaps because they're taking rest without thinking. They can be more impulsive. They have 2 to 4 times more probability to have more accidents in cars because they sometimes take more rest. They might have more probability to be pregnant as a teen or to have a sexually transmitted disease. And when we think about elementary and middle school children, the most important job is a school. So they might struggle with the school, and they might struggle with occupational achievement. And when you're thinking, if you're a child and you're 8, that's your most important job. So if you don't feel effective about doing your job, that can also have longer term impact like depression and anxiety. Kids who have ADHD and are not treated are more likely to get into substance abuse, and they might have relationship problems too. So now let's think about what are some of the differences between ADHD with epilepsy and ADHD without epilepsy. So we don't really know how seizures affect ADHD. We know that a lot of the medications, the anti-epileptic medications that we use to control seizures, can cause side effects that include inattention. And we also know that when a child is having a lot of seizures, the poor seizure control can look like ADHD. So the better seizure control, the better attention. So what comes first, ADHD or epilepsy? Some of the studies show that in the 30% of the patients, the ADHD symptoms can start before the seizures start. Sometimes parents decide to wait until the seizures are well controlled before addressing the ADHD. We know that the ADHD symptoms can affect the quality of life in youth with epilepsy, sometimes even more than the seizures. And there are different kinds of treatment, and we'll be talking about them, but we feel it's as important to treat the ADHD symptoms as it's important to treat the seizures. So the attention problems can be influenced by the kind of epilepsy your child's having, the medication side effects, the long-term impact of repeated seizures, and cognitive dysfunction. We know that certain kinds of epilepsy can have more impact on the inattention. Like if your child has frontal lobe epilepsy, or if the epilepsy is affecting the temporal lobe, can also be impacting the memory and the processing. Although we know that regardless the seizure type, the inattention is frequently present in children with epilepsy. And the common belief that, if with time things are going to get better, for children with epilepsy, that's not true. If we don't treat it, it doesn't get better, and then their quality of life doesn't improve. So when we think about some of the psychiatric disorders in children with epilepsy, ADHD is the most common psychiatric comorbidity. We said up to 40%. It can be, as we said before, impacted by all the seizure variables, also some of the anti-epileptic medications, We know that certain medications might impact the processing and the attention more than others, like tiagabine, topiramate, and zonisamide can impact more the inattention. We know that some other medications might cause hyperactivity and in some patients aggression, such as Neurontin. And we know some of the medications that we use in emergency situations like the benzodiazepine and some of the antiepileptic medications like the barbiturates are frequently associated with inattention and hyperactivity. So what happened with children with epilepsy is sometimes, like in this study, I thought it was really interesting. Children with epilepsy start struggling with the school, early in life, and then sometimes because they have epilepsy, people think, oh, it's because of the epilepsy, and they don't look into what could be some of the other reasons why this is happening. So it's very important if your child is struggling at school to definitely do more tests and make sure that they don't have a learning disability. Children with epilepsy tend to be overlooked and undertreated for their attention problems because the parents think like this is as good as it's going to get. As long as they're not having seizures, things are going to get better. But if we don't treat it, they're not going to get better. So ADHD could be a very important predictor of academic underachievement. That's why it's very important that if we think that the child is struggling, we get neuropsych testing to make sure that we address all the issues, and those issues are addressed in the IEP or the 504. So when we think about some of the psychiatric disorders, in this study where they look at 35 children with epilepsy and ADHD, and children with ADHD and non-epilepsy, they found that definitely the prevalence is definitely higher than in the general population. When Dr. Timmons-Mitchell was showing us this slide about the incidence, you can see some variability, and that depends on what scale they're using. So some scales you can see up to 57%, some scales you can see up to 40%. The important thing is, like we know, is very frequent that we see a lot of inattention, we see a lot of impulsivity, different like from regular ADHD where you tend to think that girls tend to have more inattention and boys tend to have more impulsivity. In children with epilepsy, we'll see both. And we know that after the seizures get better, the inattention sometimes can get better, but if it doesn't, then that's when we should consider to use treatment for the ADHD. So in these children, in this study, they look at the different types of ADHD, and as we were saying, you can have only inattention, you can have impulsivity, you can have hyperactivity, or you can have a combination of the three. In some of the studies, it showed like the inattention is probably one of the more frequent characteristics of the ADHD in kids with epilepsy. We also know that kids who have developmental issues like mental retardation may be at higher risk for ADHD. And ADHD and epilepsy can have a huge impact on the outcomes at school. So if we don't treat it, kids might be feeling like it's not worth it to keep trying, and the effort decrease, and of course their grades are going to decrease, and they might have a learning disability that might be impacting how they're doing. So it's very important to treat. And also when we're treated, we have to look at the EEG. So even in children without epilepsy, when they do EEGs, they have found that kids with ADHD with non-epilepsy, they might have different patterns of the EEG. So there might be a bidirectional relationship between the ADHD and the epilepsy. So as we were saying before, the inattention is very frequent, and parents and providers sometimes might be reluctant to treat these children because some of the type of epilepsy can be worse with certain medications. We will talk more about this when we touch on the different treatments. But it's very important to consult with your doctor and see what is the right treatment for your child. So what are some of these controversies? So people might say, like, you can go to a general practitioner, your pediatrician, or even some of the psychiatrists, and might say, because your child has epilepsy, stimulants are contraindicated. Because for some children, stimulants might precipitate seizures. Well, that's partially true. It is true for children with generalized tonic-clonic seizures, and it's true for children who had status epilepticus in the past. But we also know that there are several studies in children with well-controlled seizures and ADHD that suggest that there's no change in seizure frequency or increase in the seizures after the stimulant treatment. Most of those studies excluding children with poorly controlled seizures. So it's very important to contact your doctor about this treatment, both your epileptologist and your child psychiatrist. So when we talk about medication, what are the kinds of medications? We will talk about two different kinds, stimulants and non-stimulants. So the stimulants are the gold standard for the treatment of ADHD. The stimulants can reduce the ADHD symptoms and they work well. They've been on the market for more than 50 years and we know they're very effective. In children with epilepsy that is well controlled, they can be very effective too. In stimulants, we have two different families. One family is called the methylphenidate family and the other family is called the dextroamphetamine family. To date, most of the studies that we have in children with epilepsy are with methylphenidate products. There are other medications that are called non-stimulants. So we have guanfacine, clonidine, and atomoxetine. There's some studies with atomoxetine. There are currently no studies with the other ones. Different from other conditions, we feel that if your child has epilepsy, the medication should be managed by a child psychiatrist because the side effects and there might be some contraindications. So for the studies, there's around 8 studies. Most of them are with methylphenidate products. So in that family, they look at safety and efficacy in children with epilepsy and children without epilepsy, and they're very effective. We know that when children are taking medication and their symptoms are improving, their quality of life improves. And we also know that the combination of medication and behavior therapy is definitely much better than doing medication alone or behavior therapy alone or routine community care alone. So the stimulants. So as I said, there are several studies that demonstrate that the stimulants are effective in children with epilepsy with no increase in the seizures. There's one study that considers potential increased risk in those with ongoing seizures. So that's a key point. If your child is having generalized tonic-clonic seizures, if they have any generalized tonic-clonic seizures in the last 3 months, it's better not to use stimulants at this time. So what are some of the special cautions for children with epilepsy? Start slow and go slow. Like if your child is 12-year-old and you have epilepsy, normally you'll be started on a longer acting medication that stays on your system all day. But if you have epilepsy, independent of your age, we recommend that we always start with a short acting medication that is in your system for 4 hours. And then we try that dose for at least a month and make sure that your seizures are the same. So it's very important to keep a seizure diary to know how many seizures you were having before you start the stimulant and if the number of seizures increase after you start the stimulant. So we always start with short acting. We always start with methylphenidate products because there are no studies in the other family. That doesn't mean they're not effective. That means we don't have enough studies. And the same, for some patients, methylphenidate products could be great. For some patients, methylphenidate products are not so good. So when we have to switch to the different family, the same, we always start slow. We recommend to have an EEG within 3 months of starting the stimulants just to make sure that there were no changes on the EEG. And because these medications have a special risk, we recommend that they will be managed by a child psychiatrist. Their studies demonstrate that methylphenidate is effective in children with epilepsy to reduce the symptoms of ADHD, either inattention, hyperactivity, and impulsivity. So these studies that were done were placebo-controlled studies. So that means in one group they have people not taking any medication to help with the ADHD, and in the other group they have people taking the methylphenidate. And they evaluated the number of seizures, the effectiveness on the scale for inattention, and they showed that the medication was effective and safe on those patients who have well-controlled seizures. So that means they were not having generalized tonic-clonic seizures in the last 3 months. Well, there are other things that I think are important to know. There was a couple of years ago a black box warning for some stimulant medication in patients with cardiac side effects. So the current recommendation from the American Academy of Pediatrics and from the FDA is that if your child has no cardiac problems and no heart murmurs, no structural defects in the heart, your risks are the same as the general population. If your child has any history of a heart murmur or a cardiac defect, we recommend that before you start a stimulant, you should get electrocardiogram, you should get probably a sonogram, and if there's any arrhythmia, see a cardiologist before starting the stimulant. If your child never had a cardiac problem, is not having any cardiac symptoms, or was never diagnosed with a cardiac defect, the risk is the same as the general population, so we don't even have to do any of these tests. Who shouldn't be on stimulants? So if your child was ever in the ICU because of a status epilepticus, stimulants are not the best medication for your child. If the seizures, the generalized tonic-clonic seizures, are poorly controlled, if he or she had seizures in the last 3 months, we should aim for a better seizure control before starting the stimulants. Let's say your child is having like partial seizures or is having like absent seizures, even if they're having those daily, there's no evidence that those kind of seizures have higher risk with stimulants. Kids whose number of seizures increase after stimulants, we feel is very important to then stop the stimulants. And we know that children in the autism spectrum or children with developmental disabilities can have the opposite effect. So if your child is having more irritability, more mood lability after the stimulant, please talk to your doctor because it might be an effect of the medication. And because we started with the short-acting medications, you might see by 6 hours the effect is out. So it's very important to stop the medications in these cases. There are other kinds of medications, the non-stimulants. There are some studies in children with epilepsy. One of these medications is the atomoxetine. There was one prospective study that showed significant improvement in 16 out of 17 children. In one of those children, there was increased number of seizures. There was another study, but it was retrospective. So that means like they reviewed the charts of patients who had epilepsy and were taking atomoxetine, and they felt they had inadequate response, increased irritability, decreased appetite, and tremors. Some of the other medications that are non-stimulant, such as guanfacine and clonidine, we were not able to find any studies for children with epilepsy. Other third-line medications that have been used in children with non-epilepsy, such as bupropion, are contraindicated. So that means your child with epilepsy should not be taking bupropion because it can increase the number of seizures. So there are some important decisions. So sometimes parents decide to wait to treat ADHD until the seizures are well controlled. Well, that depends on what kind of seizures. If we're talking about complex partial seizures or absent seizures, the wait is not necessary. But if you're talking generalized tonic-clonic seizures, it's important that at least 3 months pass before you start the stimulant. Functional issues. If we feel like the child is having problems at school, they're not interacting well with peers, they're having problems with the family, attention is important. And if we can use stimulants at this point, there are other treatments that could be very effective. Be sure to be in very close communication with your PCP, your pediatrician, your epileptologist, your child psychiatrist, your psychologist about what to do and when. Remember, this is a team approach and everybody's here to help you, but you are the best person to know what's the best for your child and how is your child reacting to all the different medications. If your doctor doesn't know what's happening with the behavior, he can really help you. So we prefer that you contact us if you're having problem with the medications instead of stopping the medication, because of course, in the case of antiepileptics, you have to definitely talk to your doctor before making any decision about the medication. Also, if you have any concerns about worsening symptoms or even irritability or problems with the appetite, talk to your doctor. There might be special other alternatives that we can use to help with these problems. So it's very important to think that when your child has epilepsy, there are other factors that can impact their quality of life, such as inattention. So we know that the more that the inattention or the hyperactivity improve, their quality of life also improves. So there's an important association between inattention, and that brings us to a point that when you're having these symptoms, it's important to treat them and to treat them early, because as we said before, children, the most important job that they have and they feel effective on is being at school. And if they feel ineffective, then they start feeling like they don't want to go to school, they feel disengaged, and they might become depressed because of that. So looking for treatment, either medication or therapy early, could be really helpful. So now Dr. Timmons-Mitchell is going to tell us about some of the different kinds of therapies that we can use, especially behavior therapy, for the treatment of inattention and ADHD.
So Dr. Falcone has given us a really nice and detailed description of the medication options that are available to treat ADHD in children and youth with epilepsy. And now I'm going to talk about some of the big programs that exist in addition to medication, and then to talk in a little bit of detail about how you might implement behavior therapy, and give you some recommendations about where you could look for people to help you with that. So other than medication, of course, these treatments, it goes without saying, are best when they're combined with medications for ADHD in children and youth with epilepsy. One of the programs that has been found to be very helpful is the Children's Summer Treatment Program. So this is something that, this is for all kids who have ADHD as well, and children and youth with epilepsy can benefit from it too. It occurs in the summer in various different places, and it's a lengthy program. It lasts all day, and it focuses on teaching the children how to get along with other children, how to do better in their schoolwork. It also has components that help teach parenting skills, teaching you, the parents, how to deal more effectively with your child with ADHD and epilepsy, and can be a really very good program, so you might look for that in your area. Behavior therapy, including daily report cards and token economies, can be helpful. I'm going to say a bit more about that in just a minute. And combined with behavioral parent training for younger children. School-wide approaches, such as positive behavioral support, are very helpful and are implemented in many schools. And this is the kind of program that has to be implemented school-wide. So you may want to ask your school whether that exists and how they do in fact implement it. So speaking a little bit more about behavior therapy itself, which is the recommended way of dealing with individual children who have ADHD and epilepsy. So behavior therapy is designed to improve the target behavior that a child is exhibiting, to reinforce positive behavior. And a way that teachers and parents often talk about this is to catch the children being good, because what you want to do is you want to learn how to focus on the good behaviors that you want to strengthen and increase, as opposed to primarily focusing on the bad behaviors that are getting in the way. It's human nature to focus on the bad behaviors, but a lot of behavior therapy is aimed at learning how to recast that so that you're focusing on strengthening and increasing the positive behaviors. And then, of course, it's important to use these tools consistently in all settings that the child is in. So at home, at school, any other place that the child spends a great deal of time. Getting back to the team approach that Dr. Falcone was talking about, you want to involve all the people who are important in your child's life in implementing these effective techniques. So one of the things that you do in implementing behavior therapy is you want to start where the child is and keep in mind your goals. So you want to identify what are the things that you are the most concerned about, and you can develop checklists to identify those. You want to define the target behavior. So this is identifying, not strengthening, but it's clearly identifying what the issues of concern are and defining the target in multiple ways. So that would be like in multiple situations. You know, how can we think the target, for example, is, I don't know, the child at school, it could be not sitting in his or her seat, you know, getting out of the seat and running around. At home, it could be interfering with siblings' playthings. And you want to define it as clearly as you can. Both of those might be instances of poorly controlled motor activity. And so what you would want to do is strengthen the child's ability to sort of sit still and keep hands and feet to self. Well, how would you in fact do that? In goal setting, I think it's very important to include measurement in the definition of the target, because this keeps you focused on what it is you want to see changed and how you're going to know if it is changed. Oftentimes, if we focus on negative behaviors, we get so far away from what it is we want that we're not clearly focused on what it is we're hoping to see. So if we're sticking with our hypothetical child who's interfering with siblings' playthings, and you might set a goal of decreased interference with siblings' playthings as evidenced by less screaming from the other room from the child saying so-and-so's getting into my playthings, as evidenced by the target child redirecting to do things that are appropriate and on his or her own, those kinds of things, so that you frame it very clearly. So in your targets for goal setting, as I'm saying, you want to prioritize what are the most important things. And using something called the Pareto principle, I think it's very helpful to figure out what are the sort of 10% of activities that if you could affect them would address 90% of the problems. And so what you may want to do with your child is to come up with 2 or no more than 3 targets of things that you would like to design behavioral models for. And when you do that, you want to use something called the ABC model. A stands for antecedents, or what happens before the behavior. So you're looking at sequencing here. B is the behavior or the actual occurrence of what happens. And then C is the consequences, what happens after. And you want to build in a way of verifying the sources and collecting from multiple perspectives. In, again, this hypothetical example that we're using, it's not enough to hear from the sibling whose toys are being interfered with. You either want to observe what's going on or find another way of verifying the report, have somebody else observe it. So in specifying your goals and objectives, a goal would be what you, the parent, and other people would like to happen, to do, or to be as a result of the intervention. And the objectives are the limited or intermediate versions of the ultimate goal. So what it is you're going to do to try to accomplish it. You want to be focusing in behavior therapy on rewards and punishments. So it's a nicely titrated combination of carrots and sticks. Carrots are the rewards and sticks are the punishments, not literally, but things that a punishment is actually defined in behavioral terms as anything that decreases behavior, which is not the way we mostly think about punishment. Privileges must be highly desired by the child. It doesn't help if you build in a reward of something that the child doesn't want, right? If you say, I don't know, if you do something really well, you can have an extra helping of Brussels sprouts, and the child doesn't like Brussels sprouts, that's not going to be an effective reward. But if you say you can buy your favorite sugary cereal and have a little teeny bit of it, that might be a salient reward. Good behavior needs to be rewarded frequently. And by frequently, we don't mean like at bedtime. We mean like when you start out, you probably want to break the day into like half-hour segments. A lot of us are familiar with, getting through a day and thinking about accomplishing something a day at a time. But if you're trying to change a child's behavior, it needs to be way more frequent than that. I mean, even morning and afternoon may be too much. You need to reward behavior, hopefully on the half hour or hour if you can. And then you have to tie privileges, and this is kind of all privileges that children have, except that the ones that they need for growth, to a specific rule. Let me say just a word about growth privileges. A lot of times parents will say, well, in order to be able to do something that you like, we're going to put everything in that category and they're all privileges and you have to earn all of them. That's going a little too far, because something that a child might enjoy might be, for example, participating in a Boy Scout outing or attending a practice of his hockey team. And those are both things that we call growth privileges, and we never ever take those away. The reason is because children with ADHD really need the socialization, and we don't want to remove them from situations where they might, in fact, be able to do that in a positive way. We also want to match the rules to the developmental level of the child. You don't want to demand, for example, that a 4-month-old sleep through the night before getting a particular reward. Most people aren't using rewards for 4-month-olds, but the idea that it has to be something that the child can accomplish, and it also has to be something that the child has mastered previously. So you're not making rules about skills that haven't emerged yet. Rules and privileges have to be discussed with the child before being implemented. A lot of times parents will fall into the trap of something called mood-based discipline, which is to say, well, you know, you just violated a rule, when that has never been discussed as a rule or laid out to the child. A child doesn't have a reasonable opportunity to change their behavior if they don't know what's expected. And finally, about rewards and punishments, if there are two parents, both parents must develop the rules jointly and administer the rewards consistently, and then also communicate consistently with all of the other people who are interacting with your child. This is a sample of a behavior chart that you can develop and use. These may look kind of cumbersome to begin with, but it turns out that there are lots of places on the internet that you can find examples and then modify them. Or if you're good with any kind of word program or spreadsheet program, you can come up with your own. The headings are the things that you want to pay attention to. The first is the rule, which has to be well specified behaviorally. So the example here is that we're talking about a hypothetical child named Tia. So Tia stays in classes all day each school day. That's the rule. The privilege, if she accomplishes that, is that she can go out until 8 p.m. after her homework is done. I'm guessing that she must be sort of an older elementary or middle school age child. The consequence, if she doesn't follow the rule, is that she can't go out after the homework is done, and she can't use her cell phone or her computer. And then you put down the day, and at this point you're just recording daily, and then whether or not that was accomplished. A lot of people think that restricting screens, like cell phones and computers, is an overly harsh consequence. You couldn't restrict it, for example, if Tia had an assignment that due the next day that she had to do on the computer. You'd have to make sure that she gets her homework assignment done on the computer. But after that, you would then restrict the optional use. And it turns out that thinking about restricting screens is a good idea, because there's a lot of research now that says that if children are exposed to 4 hours or more of screens of any type in an individual day, it can predispose them to depression and other kinds of difficulties. So we want to be careful with that. So this is an example of the process that you might go through if you were developing a behavior therapy plan with a child, so that you might work on goal setting, identifying targets, identifying rules, rewards, punishment, and keeping behavior charts. And you could work on that with a child psychologist, be a good person to help you to institute that, and it can be very helpful in working with your child. So we want to thank you for attending our webinar today. Dr. Falcone and I are really delighted that you were able to make the time to hear some of what we had to say, and we hope that you find it useful. Thanks.